Thank you again for joining us this afternoon for today's Doctors In program on depression and mental health. For any of you who are new to Doctors In, this is a program partnership between the LGBT Elder Initiative at the William Wade Community Center with the Jefferson Center for Urban Health and the Jefferson Department of Family and Community Medicine, which houses the geriatrics division, as well as the hospice and palliative care unit. And so we do these programs monthly with Jefferson doctors coming in each month to present on a different medical issue, a different health topic relevant to members of our community. We've been doing this for a couple of years now, made the shift this past year to start doing these as webinars, and appreciate all of the Jefferson folks for still having the commitment to this community education, even with all the other things that you've been juggling in the health system this year. And so thank you again for all of that work. Before we get into today's program, I'm just going to turn it over to Dr. Liz Spina, who has an announcement that she wanted to share today. So Liz, take it away.
Thank you. I wanted to tell you all about a photo submission we're holding at the Center for Healthy Aging. We are displaying images of our patients and the Philadelphia community within our halls, and it was really important for us to have those photos reflective of the people that we care for and love for. And we've created such a great relationship with the LGBT Elder Initiative. We only felt like it was important for us to share this opportunity, submit your photos as well. Our theme is memories of love. So we are encouraging people to submit their photos, doing things that they love to do, being with people that they love to be with, whatever the case is, as long as it's connecting healthy aging and love together. And you would be able to submit these photos to an email, which I'll submit in the chat. Along with that submission through the email, there's also a waiver form. And those would be all reviewed by the physicians here and hand selected to hopefully hang in our offices and really kind of be a great memory of Philadelphia. And so we hope that you would join us in this. So I will submit the flyer and I hope to see your pictures. So if any of you are crafty, thank you.
Awesome, thanks Liz. And we appreciate the opportunity to make sure that, and the effort to make sure that we're being inclusive and including our LGBTQ plus communities in these efforts. So we're going to welcome now Dr. Zachary Klock, who is I'm sorry, Zach, are you a geriatric fellow or a palliative care fellow?
I'm a palliative care fellow.
A palliative care fellow at Jefferson, and did one of these Doctors In programs with us in the fall, and we're excited to have you back for another one. Also, welcome to Dr. John Leantonio from Jefferson, who's on here with us today as well. Before Dr. Klock gets going on the presentation, just a couple of logistics for anyone newer to the Zoom webinars. You should all be able to type in the chat. If you type in the chat, this is a place that you can ask questions, share any resources. We sometimes get some nice resource sharing going in these Doctors In webinars. Just know that if you are putting something in the chat, your name is public. So if you are asking any more personal questions or anything that could have more personal information, we advise you to use the Q&A feature, which you can also find in the toolbar at the bottom of your Zoom screen. The Q&A, there's an option to submit your questions anonymously. So that is also an option if you'd rather not have your name attached to your question or to the issue that you are sharing about. But we'll be keeping an eye on both the Q&A and the chat, and I'll be relaying any of your questions to Zachary as he goes through the presentation. Feel free to sort of ask those as we go. We may hold some of them until the end if it's content that Zach is going to get to later in the program. Without further ado, please welcome Dr. Zachary Klock.
Awesome. Thank you so much, David. It's awesome to be back here with all of you again. Like he said, my name is Dr. Zachary Klock. I'm a palliative medicine fellow at Jefferson. I'm a family physician by training and also did my residency here at Jefferson, so I've been around for a while. For those of you who are unfamiliar with what palliative medicine is, we're really kind of a subspecialty of medicine that helps patients who have, serious chronic illness, to help to support them and their loved ones throughout their illness course, to help them to make decisions about their care and to help them with any pain and symptom management that comes along the way. We see patients in the hospital, in the office, so certainly we are a service that, if it's unfamiliar of you, may be of benefit. So it's great to be with all of you. Our topic today is going to be on depression and mental health, which is, as I'm sure you can imagine, a pretty broad topic. So I've kind of highlighted some things that I think are kind of relevant and most important to all of us. But I certainly welcome any thoughts or questions that you have throughout the talk. Feel free to use those features that David was talking about, so that I can help to answer the questions and get you guys the information that you're hoping to get out of this. I did want to say Jillian Love is another palliative medicine physician who helped in making these slides, but she was unable to join us today. So I wanted to give her some credit. She did all of the cute animal pictures that you will see throughout that may help to brighten your day a little bit. So in terms of kind of a brief outline and things I'm hoping to discuss and cover today, we'll start by talking about some of the epidemiology surrounding mental health. We'll talk about definitions as well as symptoms of common mental health conditions. We'll talk a little bit about management options, and then give you guys some resources as well that may be of use. In terms of the epidemiology of mental health, it's fairly common in the United States. There's certainly stigma that is associated with it, but about 20% of US adults, which is about 43 million people, have some form of a mental health condition, with anxiety and depression being the two most common and the two that we'll really kind of talk most about today. The highest rates of anxiety occur in people aged 45 to 49, with women being twice as likely to be diagnosed with anxiety as men. However, nearly a third of adults report symptoms of anxiety to their primary care provider. So certainly a very, very common feelings that people have. And unfortunately, less than half of adults with mental health conditions receive the appropriate mental health care that they need, which is certainly a huge disparity, and something that we should be working on. And hopefully through education, we can help to recognize some of the signs and symptoms of mental health so that we can encourage people to be seeking help sooner so they can be diagnosed and managed appropriately. In terms of depression in particular, in any given year, 6.5% of US adults have at least one episode of major depression, and 4.3% have a major depressive episode with some sort of severe impairment, whether that be in their personal or professional life. So certainly something that is quite common. In terms of mental health in older adults in particular, we know that in general, older adults do have higher rates of mental health problems. About 20%, which is 1 of 5 of older adults, older being adults over the age of 50, have some form of a mental health condition. About 6% of that population have a diagnosable depressive illness in any given year. Though, as we talked about in terms of diagnosis and seeking out care, this number is probably underreported as to the number of people who are truly experiencing depression. In terms of our older adult population, the highest rates of depression occur in those aged 50 to 64, and have higher rates in women. And also Hispanic older adults have higher rates of depression as compared with other races. And as I mentioned, the incidence of depression increases in older adults compared with younger counterparts. And we talked about how 50% of the general adult population doesn't have appropriate mental health care for their mental health conditions. And 2 out of 3, or 66% of older adults who have a mental health condition, they don't receive appropriate services or treatment. So certainly kind of a huge gap in recognition, diagnosis, and treatment in our older adult population. In terms of mental health in the LGBTQ+ community, we know that members of our community have higher rates of mental health illnesses as compared with heterosexual counterparts. It's reported that approximately 40% of all LGBT adults report having a mental illness in the past year. And in our community in particular, we know that bisexual adults as well as trans adults have higher rates even compared with the other members of the LGBT community. Trans members of our community in particular are at significantly increased risk of suicide attempt. 40% of trans individuals have attempted suicide in their lifetime, which is 9 times the national average. So really, really significant. And in particular in the LGBT community, in addition to kind of depression and anxiety and other mental health conditions, LGBT individuals are twice as likely as heterosexual counterparts to have a substance use disorder. And we'll talk a little bit about this since this is certainly, a unique part of our demographic. In terms of the cost of mental illness, it's expensive. It costs our country a lot. This is some numbers. They're old. It's about a decade old from the Substance Use and Mental Health Services Administration, SAMHSA. And the estimated national expenditure then was around $147 billion. And when you account for lost earnings and disability related to mental health conditions, lost work, time out of work, things like that, in 2012, it was nearly $500 billion that mental health costs. So certainly a big financial impact in addition. This is another cute animal picture from Jillian. So now we're going to move into kind of talking about definitions and symptoms of some of these mental health conditions, some common mental health conditions. And, before we go into this, I just wanted to note that mental health disorders within the kind of medical field and medical community have very specific kind of definitions and diagnostic criteria that we utilize to make a diagnosis of a mental health condition. And sometimes these may differ from the words or diagnoses that people use kind of in normal vernacular. And so I'm really going to be approaching this from the standpoint of a physician and the medical definitions, but I want us to remember that, there are some mental health conditions that are used very differently in the vernacular. One of the most common ones that I think about is something like bipolar disorder, which in medicine has a very specific set of diagnostic criteria. And I think in our vernacular, we often use bipolar to describe people who go through quick highs and lows, or whose mood can quickly change from being happy to being sad 1 minute, or being angry 1 minute. And that's different than what we think of in the medical community. So I just wanted to emphasize that as we kind of talk about some of these conditions and really the medical definitions and symptoms that are associated with them. Hopefully you can use some of the symptoms in particular to either recognize concerning symptoms in yourself or your friends or your loved ones, so that if you are worried that maybe you have something like this that needs to be managed, that you can seek out the appropriate attention. So depression is, certainly one of the most common, and this is, a common mental health diagnosis that I'm sure all of us are familiar with. We either suffer from it ourselves or know someone who is dealing with depression. And this is really a group of mood disorders that causes symptoms that affect how you feel, think, and handle daily activities such as sleeping, eating, or working. In terms of some of the common symptoms that you may notice in yourself or a loved one for depression are feelings of hopelessness, a loss of interest in activities that normally bring you interest or pleasure, difficulty with concentration, feelings of guilt. Depression can certainly manifest in somatic symptoms and physical pain. Changes in sleep, changes in appetite, changes in weight are all common symptoms of depression. This is kind of a more thorough look at some of the warning signs or symptoms of depression and some of the things that your doctor may be kind of asking you about as they're trying to kind of tease out what exactly you're experiencing and attempting to make a diagnosis of a mood disorder like depression. Things like noticeable changes in mood, energy level, or appetite, both difficulty sleeping, but also sleeping too much can be signs of depression. Difficulty concentrating, feelings of restlessness or feeling on edge, increased worry, anger, irritability, aggressiveness, sadness, hopelessness, difficulty feeling positive emotions, a need for drugs or alcohol, suicidal thoughts or actions, changes in cognition or memory, and unusual thinking or behaviors that concern people. And really the thing that we certainly think about and worry about are thoughts or behaviors that interfere with work, family, or social life. So certainly, many of us, all of us probably have experienced, a feeling of sadness or anger or worry or stress. But really it's when we think about it interfering with, your normal daily functioning, your work, your family life, your social life, is when we certainly start to get worried about your symptoms. In terms of risk factor for depressions in older adults, there are kind of some specific risk factors. Certainly we know that older adults are experiencing similar stressors to younger adults, but they may have some particular stressors that may be risk factors for depression. Things like functional decline, changes in mobility, loss of capacity or independence, bereavement and loss. As we get older, we are more likely to have friends and family members who are passing away, which can put you at risk for depression. Social isolation, certainly in the past year, I'm sure many of us are experiencing social isolation and have noticed how that affects our mood. Widowhood is a risk factor for depression in older adults, again, kind of going along with social isolation. Older adults with regular alcohol use are also at increased risk for depression. Which came first, the chicken or the egg? Sometimes alcohol use can predispose to depression, and sometimes depression predisposes people to use alcohol as a coping mechanism. Socioeconomic changes associated with retirement can certainly increase the risk for depression. And chronic health problems also increase the risk for depression in older adults. And going along with that, we have, a substantial body of evidence that shows that older adults with chronic health problems who also have depression generally have poorer health outcomes. So, adults who have heart disease and concurrent depression are at risk for worse outcomes and more severe heart disease than those who have heart disease without depression. So kind of one of the important reasons to screen, detect, diagnose, and manage depression, particularly in older adults and patients with chronic health problems in general. I want to emphasize that depression is not a normal part of aging. Certainly we talked about some of those life stressors that you may experience, but if you are having symptoms of depression, I really encourage you to reach out and to speak with your physician, because it is not a normal part of aging, and we should work together to manage your symptoms. In terms of, so depressive disorders is kind of a group of mood disorders. The most common one, and the one, when someone says depression, what they're generally referring to is the second one, major depressive disorder. And again, all of these kind of have different diagnostic criteria. That is not, important for you to tease out the differences, but your doctor will probably try and figure out, because the treatment may vary somewhat. Dysthymia is kind of a longer, less severe form of depression. So your symptoms may not be as severe, but you may notice they go on for longer periods of time than someone with major depressive disorder. Major depressive disorder is also called unipolar depressive disorder, because it really has one pole, the pole of depression, as opposed to bipolar disorder, which has two poles. It has depression as well as mania. And again, mania has kind of its own criteria and set of diagnostic criteria. So, your doctor may ask you questions about your sleep patterns, about your energy level, about risk-taking behaviors, things like that, to help determine whether you're experiencing bipolar, which would have a different treatment modality. Postpartum depression is common in women after they give birth, and you may know someone in your life who experienced postpartum depression, and that would certainly put people at risk for depression later in life if they had postpartum depression. Seasonal affective disorder is kind of related to winter and cold and sunlight, less sunlight and being inside. Adjustment disorder is kind of a normal adjustment to some sort of life stressor where you will feel depressive symptoms that are generally short lasting, on the order of a month. So you may see, your doctor may diagnose you with adjustment disorder after, a loss of a job or a change of a job or a movement from, the house that you've lived for 30 years into a retirement community or a senior center or something like that. You may have an adjustment disorder, which is really a shorter self-limited period of these symptoms. And bereavement we'll talk specifically about in a little bit. Right here. So grief and bereavement are kind of two sides of the same coin, so to speak. Bereavement is the experience of losing a loved one due to death. And grief is the natural stress response to bereavement, and it can involve both physical and emotional symptoms. So if you have ever, experienced sadness or anger or guilt or anxiety or fatigue, tiredness, headaches, not eating as much after a loved one has passed, that is kind of the grief reaction, the body's natural reaction to the stress response of bereavement or loss of a loved one. The symptoms will typically peak 1 to 2 months after the loss and generally improve 6 to 12 months after a loss. There are kind of other components of grief. There are things like complicated grief, which is, a very intense or a very prolonged grief reaction. So certainly if, months after the passing of a loved one, you are still having significant either physical or emotional symptoms, or years after a passing, then it may be worth discussing with a physician or your provider. Certainly nostalgia and thinking about someone and remembering good memories or good times and maybe a sadness associated with that is not typically grief. But if you're having persistent symptoms or symptoms that are impairing your life, it would be worth reaching out to someone. And some people experience what's called anticipatory grief, which is, if you have a loved one who is terminally ill and who is dying, and that they are going to be dying in the coming, days or weeks or months, some people will experience the same physical and emotional symptoms as they are preparing for the loss of a loved one. And that's a very normal reaction to preparing for the loss of a loved one, that anticipatory grief. Again, certainly if you're concerned about your symptoms or you feel like your symptoms are having a significant impact on your life, on your professional, personal life, those would be reasons to reach out to someone so that they can help with management of those symptoms. But in general, grief is really a natural response to this stress of losing someone. Kind of moving on to the next common group of mental health conditions that we see in patients is anxiety, which is, really, I'm sure many of us have experienced feelings of anxiety before. It's a feeling of excessive anxiety or worry or fear about numerous things, whether they be personal, work, health, everyday activities, that again cause significant problems in areas such as work, school, personal, or social life. Symptoms that are associated with anxiety that you may recognize in yourself or in a loved one are things like restlessness, feeling keyed up, feeling on edge, worry, irritability, muscle tension, sleep disturbance. These are all some symptoms that you may notice associated with anxiety. I think it's important to note that many of us experience anxiety as a normal physiologic human response to some stimulus or event. And again, kind of talking about, as we're talking about with depression and bereavement and things like that, is when the symptoms are really becoming burdensome to your life or having an impact in your personal or professional life, or affecting the things you like to do or your normal routine, is really when we start to get worried about, a significant anxiety disorder. Um, in terms of the common anxiety disorders that we see or that you may be diagnosed with, general anxiety disorder is kind of the most common one, and that's really just a generalized anxiety, those feelings of anxiety and worry and fear related really to any sort of stimulus or thought. It's generalized. It's not really around one specific thing. Panic disorder is, similar to a generalized anxiety disorder, but it's really a pronounced panic attack, as one thinks about a stress or an anxiety. And what that panic disorder or panic attack response usually looks like are things like your heart may start to race, your breathing may get really heavy, you may feel short of breath, you may start to sweat, you may start um, to feel lightheaded or dizzy. Those are all kind of symptoms of a panic attack or a panic disorder. And those symptoms can last on the order of seconds to minutes, sometimes even longer, in hours. Um, PTSD, post-traumatic stress disorder, is really an anxiety disorder that is, a prolonged anxiety, a prolonged worry or fear related to some sort of stressful event. Certainly, we hear about PTSD and think about it a lot in our veteran community and those who have seen combat. But really, you can have a response to any sort of traumatic event. A response to a dog bite, a response to a car accident, a response to really anything can cause PTSD. And with this, you'll have those feelings of anxiety for months to years, particularly when you think about that event, or when you're in the same location or somehow triggered to remember the event. And it can manifest with things like flashbacks, and many people who have PTSD will have significant sleep disturbance and will have nightmares or dreams that really affect them. OCD, obsessive compulsive disorders, is another one of those, like bipolar disorder, that I think we use very differently in the vernacular. OCD is really a set of obsessive tendencies that one must do that really creates significant stress or impairment in one's life. So again, there's a very different medical kind of criteria than just the like, oh, I like to clean my kitchen, I like my bathroom to be clean, I like to have all my papers in the same orientation on my desk. Those may be obsessive tendencies, but it's really not rising to the level of obsessive compulsive disorder, which really has some sort of impairment in your life or your functioning. And again, adjustment disorder that we talked about, which is really kind of an acute, generally a month, normal emotional response to some sort of change or adjustment in your life. I did want to touch some on substance use disorder, just because we know that this is something that disproportionately affects LGBTQ plus individuals. And we know, as I said, that their rates of substance abuse or substance use disorder are higher compared to heterosexual counterparts, and in particular in younger LGBT patients, both adolescent and young adulthood. Some studies on alcohol dependency in particular cite that around 25% of LGBT adults have moderate alcohol dependency. Substance use disorder is kind of a rainbow term that can refer to alcohol use disorder, it can refer to opioid use disorder, it can refer to polysubstance abuse disorder, which is use of multiple different substances. But we know alcohol in particular is alcohol use disorder is common in our community. And we could, certainly talk about reasons for that, of which there are many, minority stress response, historical reasons that, bars were really places that in particular older adults would feel safe going and congregating with other members of the community. There are all sorts of different reasons why this is more common in the LGBT community. I think people will often ask, how many drinks a week is too many? How many drinks a week is alcoholism or substance use disorder. And it's really not about kind of number of drinks. It's related to your kind of feelings and relationships towards a substance. And I'm going to talk particularly about alcohol, but this would certainly apply to opioids, cocaine, methamphetamines, any substance. And whether or not it has an effect or an impairment similar to depressive and anxiety disorders, what is the effect or impairment on your normal functioning? So some of the symptoms of alcohol use disorder, and again, you can kind of extrapolate these to other substance uses, would be things like a strong desire or craving to drink, an inability to control cravings, an inability to stop drinking, increased tolerance for drinking, lying about drinking, or attempting to drink without others knowing. So those are kind of some of the symptoms that you may notice in yourself or in a friend or a loved one that may raise your concern. And then kind of the impairment of your life or things that you may see are someone may be neglecting their normal responsibilities, whether it be personal, professional, social. They may have problems with family or friends that are because of drinking, and may even have legal problems or drunk driving, things like that, which is really when you get worried about the impairment on your normal function, your normal life. I don't really go into details about medical management, but I want you all to know that the medical management exists for substance use disorder. We have medicines that can help with smoking cessation, with stopping cigarette smoking. We have medicines that can help with alcohol, can help to decrease cravings, things like that. And we have medicines that can help with opioid use disorder as well. So, never be afraid to discuss with your primary care provider if you or a loved one is concerned about substance use. There are things that we can do to help you medically and help to kind of plug you into services that may be able to help. So, another cute animals. I'm going to talk a little bit about diagnosis, just kind of to give you an idea of what kinds of things your physician or your provider may ask you to do in the office that we use to help us to screen for and diagnose mental health disorders. So certainly if you are worried, either yourself or a loved one expresses worry or concern for you, I encourage you to schedule a visit with your primary care provider. Telehealth has become really popular since the pandemic and is a really great way to make a visit with your provider a lot more accessible. Depending on kind of your symptoms and your history and what sorts of lab work and things have been done in the past, your provider may decide to check lab work to make sure that there's not an underlying metabolic or other reason for why you may be experiencing the symptoms that you're experiencing. But don't be concerned if your provider doesn't check lab work based on kind of your history and what they know about you and what labs they may already have on file. Some providers will have you do a formal screening, which we'll talk about. And so they may hand you a piece of paper, at the front desk or before they see you with some questions on it. Some providers may not use that and will just kind of ask you some of the questions and some of the symptoms that we talked about earlier. In particular, there are things like PHQ-2 and 9. This is a depression scoring. The GAD is for generalized anxiety. This is 9 questions, 7 questions. And then the GDS is a particular tool to screen for geriatric depression. It's a longer questionnaire, but is something we use in older adults. Something I did forget to mention earlier that I wanted to bring up is that in older adults in particular, signs of what we call pseudo-dementia, so someone who has changes in their cognition or how they think, can sometimes be a sign of depression. So if you notice that in yourself or a loved one or your partner notices, signs of cognitive impairment or changes that are atypical for you, that can also be a sign of depression in older adults. But anywho, your provider may ask you to fill out some of these questionnaires. Some of these are really brief screening, like the PHQ-2 is 2 questions. And where I used to do primary care, we would do this on every patient once a year just to make sure that we're screening everyone yearly for depression so that we can address it if necessary. This is what the tools kind of look like. So the PHQ-9 is a screening instrument for depression. So it'll ask you, a lot of those symptoms we talked about, and it's going to ask you to say, thinking about the 2 weeks, have you been bothered by any of these problems? Not at all, several days, more than half the days, or nearly every day. And it'll ask you about literal pleasure in doing things, feeling down or hopeless, sleeping too much or too little, changes in appetite, trouble concentrating, things like that. And it's really just important to think about, the past 2 weeks, to be honest with yourself and your PCP as you fill this out so that we can, best assist you. The GAD-7 is a similar tool. It's, again, thinking about the last 2 weeks. How often have you been bothered by the problems? Feeling nervous or anxious, not being able to stop or control worrying, trouble relaxing, worrying too much. And again, you want to be honest with your answers so that we can screen and diagnose and treat you appropriately. I'm going to kind of get into some of the management techniques and principles so that, they will have some more clarity for you. I just wanted to pause and make sure that we don't have any questions or anything in the chat that I can answer right now.
Doesn't look like anything's come in thus far, but do encourage people again to feel free to put things in the chat or the Q&A.
Awesome, thank you. So in terms of management of mental health condition, your primary care provider can manage most mental health conditions, and many of us do. About over 50% of mental health care in the United States is done through a primary care physician. So don't be afraid to reach out to your primary care physician to talk about this. A psychiatrist is a medical physician who specializes in the diagnosis and management of mental, emotional, and behavioral health disorders. Your primary care may refer you to a psychiatrist depending on kind of their comfort level and how their management of you has gone, but you can certainly start with your primary care provider. I know in the city of Philadelphia in particular, there's a real dearth of psychiatrists, and sometimes can be quite a lengthy wait list to get in. So I would encourage you to seek care from your primary care provider, who's going to be much more accessible and can help to begin the management sooner rather than later. And if your PCP doesn't refer you to a psychiatrist, that's okay as well, as long as you feel like your symptoms are being addressed and properly managed. So in terms of treatment modalities, we think about, pharmacologic, meaning medicines, and non-pharmacologic, and really the overlap and combining both of these methods is where we're really going to focus and what's going to get us the best outcome. I'm going to talk a little bit about each of these. Obviously, my kind of area of expertise is more on the pharmacologic side, but I will touch, briefly on the non-pharmacologic side. Most, primary care practices at Jefferson, for example, we have behavioral health consultants and psychologists and people like that embedded in our practice who, really help us to partner together to meet in this overlap area. So just kind of some basic principles I wanted you all to be aware of if you are either, currently being managed for depression or anxiety, or, in the future, if you have to be, if you're going to be managed for this, is that, most of the medicines that we use affect different chemicals in the brain, mainly serotonin, but some other ones. And they take on the order of weeks to months until they really become effective. So it's important to think about, for almost all the medicines that we use for depression and anxiety, that it's kind of a little bit of a long haul. Generally, I'll start a patient on a medicine at a lower dose and reevaluate them in 4 to 6 weeks to see how they're doing, to see, are their symptoms any better? Are they having significant side effects? If we can be doing better control of the symptoms after 4 to 6 weeks, I'll think about usually increasing to a higher dose, and again, reevaluating after 4 to 6 weeks. And if we're still not getting anywhere, then I think about changing to a different medicine within the class. there are all sorts of different, antidepressant medicines, and different ones affect different people differently. So, what works for your friend or your partner may not work as well for you. And I just want you to be kind of patient and really partner with your primary care provider or your mental health provider, to take the time, to be aware of the time that it may take to really get you to a good regimen that is controlling your symptoms well. Something patients often talk about or think about is, when can I stop my medicine? Depending on your history, the severity of your symptoms, if you've had symptoms before, your provider may stop it after a year or so, but I think, for the vast majority of my patients, I generally will have them on medicines for a longer period of time, just because I think that the benefits of treating depression and anxiety far outweigh, some of the side effects that may come with the medicines, but certainly worth a conversation with your provider.
And if I could just jump in on that part also,
Yeah.
is it the case that some of these medicines, if you stop them abruptly, there can be, a lot of issues with that. So it is something to really talk to your provider about, of
Yes.
how you want to taper off of these medicines.
Absolutely. Yes. You should never stop these medicines cold turkey. You should always talk with your provider first, because, some of them it is safe to stop, but many of them will have some withdrawal side effects with stopping it. So it's really important. That's a great point, that you talk with your provider about the safest way to stop the medicine. And alternatively, if you're changing from one medicine to another, about the safest way to change. Sometimes you stop one and start another, but sometimes you need to decrease one medicine while you increase the other. So that's a really great point. Make sure you're kind of working in conjunction with your physician before you stop taking any of your mental health meds. Thank you. This is just a list of some of the common medicines that you may see, and I've kind of grouped them by how they work. So kind of these medicines are the most common that we use, and all work via a similar way, Zoloft, Lexapro, Celexa, Prozac, Paxil, and then kind of gets into some other medicines that we use. So these are common ones that you may see. Again, there are so many to choose from, and everyone interacts with, people differently, and they have different side effects. So your provider will tailor your regimen to what will hopefully be most effective for you. So don't be worried if this looks different, or you're on a different medicine than your, friend or partner or something like that. I did just want to note this class of medicines here, Abilify, Zyprexa, Seroquel, Latuda. This is a newer class of medicines that are called antipsychotics that have traditionally been used for management of psychotic disorders like schizophrenia, but are gaining more and more popularity and are showing, more and more benefit in management of depression, particularly in management of, treatment-resistant depression or other things. So I don't want you, if you're on a medicine like this and you Google it and you see that it's an antipsychotic, to get worried that, your physician thinks that you're psychotic. That's not, you may be, if you're not having episodes of psychosis, we will sometimes still use these medicines to help to treat your depression. So don't get worried about that. In terms of side effects, again, these medicines, it's really variable what they're going to do for each person. So the side effects will vary quite considerably by person, and also by class of medicine. Some of the most common side effects, really the two most common and two most bothersome to patients, are GI symptoms like abdominal pain, diarrhea, or nausea, and then sexual dysfunction, which may include things like less interest in sex, erectile dysfunction, or difficulty or inability to orgasm. Other things that you may notice are things like weight gain, dry mouth, headache, fatigue. It's important when you're talking about a new medicine, whether it be for mental health or anything, that you talk with your provider about what are the potential side effects, and kind of monitor yourself for those side effects. Certainly, if you're experiencing any of these, you should reach out and talk with your provider. They might consider changing the dose, changing your medicine. Sometimes we'll augment and put on a second medicine, which will help to negate some of these. So I think it's important that you kind of talk with your provider about what symptoms to expect, and then what symptoms you may be experiencing. These are just some of the really concerning side effects. So if you start noticing anxiety, confusion, diarrhea, vomiting, sweating, tremors, muscle stiffness, difficulty in balance, all or many of these symptoms in conjunction, those would be reasons to reach out to your primary care and to probably go to the hospital just to make sure that you don't have too much serotonin in your body. These are incredibly rare. I don't think I've actually ever seen it happen in my practice thus far, but certainly symptoms that you should be wary of if they do occur. I wanted to just talk briefly about benzodiazepines, which are medications like Ativan, lorazepam, diazepam or Valium, alprazolam or Xanax, clonazepam or Klonopin. These are really kind of generally quick acting short medicines that will act, pretty instantly when you take them, and are often prescribed for the management of anxiety in particular. These medicines come with a lot of side effects, and in particular things that can be really dangerous in older adults. They can cause drowsiness, they can impair your cognition, they can impair your mobility. They're associated with increased risk of falls in older adults, which is associated with things like, brain bleeds and broken bones and things like that. When you combine these with other medicines, pain medicines in particular, or when you combine them with alcohol, they can really increase that risk quite substantially. So I want people to be aware of these medicines and the dangers that they may pose. And if these are medicines that you're using regularly, that you should really talk with your provider about the safety of these medicines. In terms of non-pharmacologic management, things like, a supportive network, having a supportive network, things like support groups, if there's, grief or bereavement or certain stressors in particular that are bringing on your symptoms. Exercise has been helpful. This should say meditation, not medication. Acupuncture, behavioral activation, therapy, which can be done through a psychiatrist, a psychologist, sometimes the behavioral health consultants or social workers can do some therapy. There are all sorts of different types of therapy that can be really helpful. And I really encourage my patients to engage at least in, starting therapy session in addition to medical management, so we can help to optimize their management and their symptoms. Mindfulness meditation is something that's becoming increasingly popular and can be helpful with anxiety in particular. And this is really the practice of being fully present and aware of where we are and what we are doing, and not being overwhelmed by what is going on around us. Daily practice of this can increase, awareness and intention in everyday life that can help to calm and reduce anxiety symptoms in particular. You can just Google these on YouTube. They have like 5-minute guided meditations, 10-minute guided meditations. I'm going to talk to you guys about some apps that may be helpful and can really help to guide you through this and really bring some awareness and centeredness to your everyday life. Certainly, there are lots of barriers to therapy, things like finances. Therapy and mental health care is generally expensive, unfortunately. Availability, as I said, in Philly, it can be difficult. Scheduling conflicts, inconvenient office locations, feelings of shame, embarrassment, all reasons that people may not be able to seek out therapy. I think telehealth has probably helped some with this, and there are, online things like I think Talkspace is like one of the ones that has like an online counselor. So there are ways to get around some of these things if you are finding these to be particular barriers, and you can always talk to your physician and see if they can help at all. This is just kind of like another little breathing technique that I like to share with patients for anxiety, and it's called box breathing. And this is something that can be really helpful, in the moment if you have a sudden rush of anxiety or feeling of anxiety, is this box breathing. So ideally, you would want to be in a silent place if possible, sitting on a chair with your feet flat, and you want to inhale for 4 counts, hold for 4 counts, exhale for 4 counts, hold for 4 counts. And you really want to kind of do this for, a couple seconds, a couple minutes, And this helps to bring balance to your mind and body, regulates your rhythm, and can help to reduce anxiety. So, think about this little box and do your 4 seconds if you have sudden feelings of anxiety or shortness of breath, or those symptoms of panic attack can be really helpful. So we're gonna skip this. I'm just gonna finish up with some resources for you. For people who are into apps, these are some apps that can be really helpful. Calm is an app that really will guide you through some mindfulness meditation. Colorify is an adult coloring book that you can have on your phone. So some people find this kind of coloring to be really helpful. So you can do it on your phone, bring it with you anywhere. Breath work is some deep breathing exercises in particular. Headspace is a lot of meditation. iBreath is some breathing exercises. So these are all certainly some apps, if you're into apps, that you can download and have to guide you through mindfulness or breathing techniques if you're experiencing symptoms of anxiety or depression or overwhelming emotion in general. And then I just wanted to share some general mental health resources. Obviously, your primary care doctor's office is always a resource. The National Suicide Prevention Hotline is here if you're having suicide crisis. If you are in crisis and you'd prefer to text over a phone call, you can text hello to this number here. And then the Trevor Project, which is, they do a lot, but it's for LGBT individuals in particular. So you can see their phone number here if you want to reach out and give them a call. And that's all I have for you guys today. So hopefully you enjoyed that kind of whirlwind of a tour through depression and mental health. And any questions that you guys have, I'd be certainly happy to answer and discuss.
Wonderful. Thank you so much, Zachary. One question that did come in the chat from Jimmy, it was one of the statistics. I think this is when you were giving some of the stats on depression, but that one of them, the highest rates were in people between 45 and 49. This might have been when you were talking about anxiety. I think it was.
Yeah, that's anxiety.
Anxiety. So the question was just on, is there a reason that we see that peak happening after 45?
I don't know of a reason. I don't know if anyone has pinpointed a reason. I would imagine it's related to things like children getting older, the rearing of teens, and or children leaving the home, and some life kind of changes that happen around that. Maybe related to kind of work experiences. I don't have a great answer for you. I don't think anyone really knows the reason for why we see kind of the higher prevalence in that age group in particular.
Got it. Thank you. Also, again, encourage folks, while we do have a couple minutes here, if you have any other questions, to please send those in. I like, Zach, that you talked about sort of the Venn diagram. Sort of there's the pharmacological and also the non-pharmacological, because I know there are things that we talk about in most of these doctors in programs about, eating healthy and exercising and setting a sleep schedule. Is there a point in your practice where you're kind of talking to people more about the non-pharmacological approaches and ways to, try to incorporate more of those things into their lives?
Yeah, I mean, I certainly think, as a primary care family doc, talking about, sleep hygiene and exercise and diet is kind of part of my normal spiel, and I try to incorporate as much as possible, whether or not people are dealing with mental health problems. Certainly when I am starting to talk about a mental health problem with a patient and diagnosing them maybe with something, I will usually I do a lot of shared decision making. So kind of talking about what medical management looks like, and then talking about the non-pharmacologic management. And I encourage everyone at that point to really focus on some of that non-pharmacologic stuff, and to think about, some of the apps and some of the, working on your sleep and working on your alcohol intake and working on diet and exercise. I certainly encourage that as soon as I'm discussing mental health conditions with patients. And then I kind of, do a lot of shared decision making around the medication piece. Some patients, you're the ones who are living in your body and are experiencing your day to day, and kind of the severity of your symptoms and how much it's truly impairing your life. And so if you feel like, we are at a point where, you would like to try medical management, then I'm open to helping you and to prescribing the appropriate medicine for you at that point. If you know it's something that you wanted to talk about, wanted to bring to my attention, feel like maybe you can, do some of the other things, then I'll generally, counsel, and we'll talk about what some of those look like. And then, I'll have you come back and see me in a month and see where we're at, and if we feel like those things are working, or if we feel like, it may be time to think about medical management.
Great, thanks. I just put in the chat one thing to add to the resources is the William Way Peer Counseling. And the phone number I have here is the phone number that they are using during COVID while things are still working remotely. But that is another free resource. It is intended to be shorter term, but over the phone, specifically for the LGBTQ plus community, and here local to Philadelphia. So I wanted to share that one as well. The other last question I had for you, Zach. Oh, that actually wasn't a question. Give it time for anyone else to ask any remaining things before we break here. I will take the moment just to announce, so in May, I think the date is May 11th, will be our next program. We are going to be talking about bone health, so issues of osteoporosis, arthritis. So we'll send out an announcement about that one. And then June, we will be talking about dementia, Alzheimer's, cognitive health, and that is June 8th. But again, we will send out the notices about that. One of the things that's also going to happen in this next, hopefully the next month, we're putting together a survey that we're going to be sending out electronically. We're working on we have our schedule set through June, but are going to be coming up with our topics for the 2021 to 2022 year. Feels weird saying 2022 already. But would love any feedback in those, because we really try to make sure that these presentations are relevant to, the health issues that you all care about, you who are coming to our programs. So do keep an eye out for that in your email. Hopefully in the next month, might not be till later in May, but we do really value your input on that. One other last thing that I would like to share just before we break. So we're working through William Way with Philadelphia Fight to do some COVID vaccine clinics. Registration is not open for those yet, but just to say, if any of you are not vaccinated yet and want to get a COVID vaccine, I'll put my email in the chat, reach out to me. I will make sure you get the notice as soon as the registration for those events open. We're just handling a couple of logistics now, but want to make sure that those are getting into our LGBTQ communities. So if there are no other questions, we will leave it there. Big thanks to Dr. Zachary Klock for leading us through this presentation. Thank you all for joining us. We're ending right on 2 o'clock, perfect timing, and hope to have you all join us again next month. Thanks so much, everybody.
Bye.